Can everyone hear me now? Okay. Let's see if I can do this. Oh, good.
It has not changed.
Shall we get started, guys? Okay, get started. All right. Hello, everyone. I'm Raj Sharma, second year pulmonary critical care fellow, and I'll be talking about pulmonary complications in hematopoietic stem cell transplant patients. And Dr. Frank will help me out with the presentation. So the objectives of this will be to cover infectious complications, non-infectious complications, and in the non-infectious complications, particularly the ones that pertain to pulmonary chronic graft versus host disease. So just to start off, we are a stem cell transplant center, and the data here is from 2018 to 2019. We're a fairly moderate size transplant center, but the numbers are increasing, and we're expected to perform more hematopoietic stem cell transplants in the future. So some of these patients, unfortunately, will develop complications, and they'll acutely either get admitted to the ICU or chronically might be seen in the pulmonary clinic. So overview of hematopoietic. I'll get rid of this. Sorry, this is in the way here, isn't it? More. Give me 1 second here. There we go. Yeah. Okay. So hematopoietic stem cell transplant is a procedure in which a recipient receives multipotent stem cells from the bone marrow, peripheral cells, or umbilical cord blood. And there are usually two types. Either the patient can get their own after getting chemotherapy, or they can get allogenic, which they get from either a related or unrelated donor. And in the allogenic category, there's the related donors, which can either be a sibling or a parent or offspring. And very rare cases, if you have identical twins, it is similar to an autologous transplant, but not exactly. But majority of allogenic transplants are usually haploidentical donors, in which half the HLA types are a match and half aren't. And then in a much smaller pool, there's unrelated donors that are matched. And then cord blood as well can be a possible match. The most common indication for stem cell transplant in the autologous hematopoietic stem cell transplants are multiple myeloma and non-Hodgkin's lymphoma. And for allogenic transplants, they're acute leukemias and myelodysplastic syndromes. Occasionally you could do it for aplastic anemia, but those are far less common. So the process of both autologous and allogenic stem cell transplants starts off with mobilization of stem cells. So in autologous stem cell transplants, usually the patient will be given colony growth factors, and they'll be extracted stem cells, usually using something similar to a dialysis catheter. These are then stored, and then patient undergoes chemotherapy, and then the stem cells are reinfused, and you wait for engraftment to occur. In the allogenic stem cell transplant, it's very similar, except the donor is someone else and not the patient themselves. So they go through conditioning chemotherapy, and then either the marrow or the peripheral stem cells are transplanted into the patient, and you wait for engraftment to occur as well. So usually the post stem cell transplant is divided up into engraftment phase, early transplant phase, and then late transplant phase. So day 0 is the day of infusion, and then 1 to 30 is usually when engraftment will occur, and they'll usually occur by day 7 to day 15, and then thereafter around day 30 to day 100, or in some cases day 180, that'll be the early post-transplant phase. And beyond that is considered the late transplant phase. And each individual section has its own infectious and non-infectious complications. So this slide, in essence, represents the bulk of the talk. In the pre-engraftment phase, we look at how the patient is vulnerable to infectious and non-infectious causes. At the engraftment phase, up till day 100, what immunological deficiency the patient has and what they'll be susceptible to. So in the early pre-engraftment phase, from 0 to 30, patients are neutropenic. And so majority of their infectious causes of comorbidities will be because of all the organisms that can affect you if you have neutropenia. As you move on and engraftment occurs, patients will have a normal neutrophil count, but they will still have cellular or T-cell deficiencies. And at that point, they're more prone to viral infections. And as time goes on, their cell counts will normalize, but they're still immunodeficient, even though they've been grafted. So at that point, they're more prone to community-acquired infections that the normal population has, and then also non-infectious causes take over. So the lungs are the most common site of tissue invasive infection, and pneumonia is the most common cause of mortality in stem cell transplant patients. And the underlying etiology of why that's the case in all immunocompromised patients, and especially in transplant patients, is because of mucosal breakdown along with immunodeficiency, and other factors of chemotherapy and radiation to the lung prevent innate barriers to remove pathogens from the respiratory tract. And this in turn becomes a portal of entry for dissemination that causes invasive infections, which ultimately leads to an increase in mortality. And this slide shows that in stem cell transplant patients, especially, pneumonia is the leading cause of death. So the first aspect of transplant is the pre-engraftment period from 0 to 30 days, but usually engraftment will take place around day 15 or so. And here the immunological deficit is usually neutropenia and mucosal damage. So the patient at this point is susceptible to bacterial infections, fungal invasive infections, and Pseudomonas. So here at our institute, we'll prophylax the patients. So the table on the right is taken from our protocols for prophylaxis in post-transplant patients. So we will give them Cipro 500 twice a day until their neutrophil count gets over 500, and that has to be for 2 days. And we'll prophylax them with acyclovir for HSV and fluconazole or voriconazole if they're an allogeneic stem cell transplant. And this limits the chances of infectious causes of pneumonia, but it doesn't completely exclude it. After that, once engraftment occurs, now patients will have impaired cellular immunity, and here is where they're most susceptible to CMV reactivation and invasive disease, so they can still get invasive pulmonary aspergillosis or mucor. For CMV, unfortunately, in transplant patients, the prophylaxis that we have with acyclovir and foscarnet, that can destroy the graft. And so it's myelotoxic. So we'll get CMV levels, but we can't really prophylax them with those two agents. But in high-risk patients, we can use letormovir. I'm mispronouncing it, but this is not myelotoxic. So especially in patients who are CMV recipient positive but donor negative, those patients are at highest risk of CMV pneumonia. So for those patients, we'll definitely prophylax them with letormovir, and this fortunately is not myelotoxic. And in those patients, we'll also prophylax them for encapsulated bacteria, so they'll get penicillin as well. So the workup for early post-hematopoietic stem cell transplant patients, if they have acute respiratory symptoms, we'll obviously get imaging, and these patients will almost always get a chest CT. And in this case, you're going to look for pulmonary opacities on the chest CT, and you almost always want to try to get tissue cultures in these patients if possible. If they're stable enough, get bronchial alveolar lavage on them. That really helps guide identification of organisms, and there's a net mortality benefit if you can identify the organism on BAL as opposed to if you can't. And if there's no pulmonary opacities, there can still be an occult infection. If unfortunately you don't get an identification of an organism on BAL and you don't think it's a respiratory infection, then you look at non-infectious causes in the early engraftment period, which some of them in itself can carry a very high mortality. And if there's no pulmonary opacities, it doesn't necessarily mean that there is no infection. Still think of PCP, toxo, and viral pneumonia. So what we traditionally will order on a BAL here, this is in our solid organ transplant patients. So in lung transplant patients, we'll order this, and usually in hematopoietic stem cell transplants on a BAL, we'll order the same thing here. The one thing that we don't usually order is galactomannan on the BAL, even though there's a high positivity. From what some of the staff were telling me is that almost all of the patients that we bronch into a galactomannan antigen on the BAL, they come back positive. So there's no net utility of getting galactomannan antigen on the BAL. And this goes to show if we do early BALs in patients who we suspect have infection after stem cell transplant, and we can identify the organism, there's an improvement in mortality as opposed to if we do the BAL late. So if a patient can tolerate undergoing a bronch early in their infectious, early in their respiratory distress, they should definitely get a bronch. So the approach to pulmonary complications in hematopoietic stem cell transplant, we'd want to look at a few things. Know the time since transplant, whether it's allogenic or autologous, the degree of immunosuppression, and that's usually in patients with allogenic stem cell transplants. And then if they have a history of chronic graft versus host disease. If we know these four things, we can refine our differential into infectious causes or non-infectious causes, and what type of infectious cause would be pertinent at that time. And then we look at the HSCT to refine our differential diagnosis. So this is for, this manifestation on the CT can occur in any of the stem cell transplant patients. So as a thought experiment, if we want to go to the left corner here, right here, what do you guys think? Just shout it out. Nodular opacities, yeah. Differential for this. Infection, yeah. So we'll name out what types of infection do you guys think this could be? Yeah, always bacterial, viral. Anything in particular? Usually invasive, aspergillosis, nocardiasis, mucormycosis. How about here? What do we see here? Possibly. What about these ones right here? What is this? How? Septal thickening, very good. So what would be the differential? Yeah, edema is possible, so non-infectious very much could be cause, but what about in infectious causes? What do you think? It's usually atypical bacterial pneumonias. How about here? Cavitary lesions, right? So what's in our differential for cavitary lesions? Staph, definitely. Anything else? Nocardia is very good, yeah. Aspergillus, mucormycosis, right? And histo as well. How about here? What do we see here? Yeah. So it kind of looks like a nodule that started cavitating. Yeah. So differentials for that would probably be the same as this, right? And this right here. So same bacterial pneumonia, mucoractinomyces, aspergillosis. How about here? Yeah, so what do you guys, what's the pattern here? Consolidation, yeah, bacterial pneumonia, aspergillosis. And here? It's just fusions, right? So TB or bacterial pneumonia. How about here? Ground glass, what do you guys think? Yeah, organized pneumonia can present a ground glass vascular, yeah, and then viral pneumonias, right? And then how about here? You may not be able to see it really well. Like, how about these, like over here? like micronodules, right? Yeah. So bacterial, viral, the differential is for any, the question is like, can you look at the pattern and can you determine what the organism might be, or can you narrow your differential down? And they actually looked at this, and the only, pardon me? Oh, sorry. Okay. They actually looked at the patterns of infiltrates in bone marrow transplant patients, and they found that the one that made it increased your pretest probability of identifying the organism was if there was a halo sign, and that was usually for aspergillosis or mucorp. And then, like you guys mentioned, always remember non-infectious etiologies could mimic infectious etiologies, right? So if there's diffuse airspace disease, as much as we thought it could be CMV or PCP, it could also be edema, DAH, and pneumonitis. Consolidation, as much as it could be bacterial pneumonia, it could be organizing pneumonia, as Hafsa mentioned, and infarcts and pneumonitis. Nodular patterns can have reoccurrence of the initial leukemia or lymphoma, or there could be a sarcoid-like response. So if we divide up our phases of post-transplant, in the early phase, think of neutropenic damage with bacterial pneumonias and invasive pulmonary aspergillosis. In the 31 to 100 days, think of cellular deficiencies, so T cell deficiencies, and usually at this point you can get both invasive pulmonary aspergillosis and CMV viral pneumonias. And then beyond 100 days, it's non-infectious mostly, but you still have humoral deficiencies, so you can get you're more prone to community-acquired infections. Okay, and then if you look at the non-infectious side, in the same timeline, in the early phase, you'll get pulmonary edema, diffuse alveolar hemorrhage, or engraftment syndrome. And then in 31 to 100 days, you could still get idiopathic pneumonia syndrome, which we'll talk about details of, or you get acute graft versus host disease, in which lung infiltrates are a later manifestation. Pulmonary cytolytic thrombi are usually a pediatric entity, but in some patients who got their transplant at the age of 18 or so, they might show up in the adult wards. And then beyond 100 days, usually non-infectious causes, where we'll talk about a pulmonary chronic graft versus host disease, Ehrlich syndrome, which is usually mediastinum or pneumothorax, PTLD, which we won't talk about, and veno-occlusive disease, also usually in pediatric patients. All right, so this is a slide taken from Dr. Ramesh's talk on infection in the immunocompromised. 54-year-old woman received allogeneic hematopoietic stem cell transplant 4 months ago. She's on high-dose steroids for the treatment of acute graft versus host disease. She's admitted with low-grade fever, cough, and left-sided pleuritic chest pain. What do you guys think? Yeah, right from here, right? Okay. So Aspergillus falls under invasive fungal infections, and usually you'll see the following patterns: well-circumscribed nodules, plus or minus a halo sign. And in the later version of it, you'll get air crescent sign, and eventually these can cavitate as well. So if you look here, we'll see the nodular density with halo sign, and this is usually a manifestation of invasion and occlusion of the small to medium pulmonary arteries, and they in turn lead to necrosis and hemorrhage. And once they infarct, that's when you start seeing the halo sign. We talked about galactomannan antigen testing, especially on BAL here. Unfortunately, there's a very high positivity rate, so BAL, GM antigen testing is not done. But for bone marrow transplants otherwise, the sensitivity is about 76%, it's 94% specific. On the right here is what we'll use for prophylaxis. We can either use voriconazole or posaconazole. And here's the question. So in the setting of invasive aspergillosis, what does the halo sign actually represent? What is it? Hemorrhage, very good. Okay. And usually halo sign's more specific for aspergillosis in the neutropenic phase, but after engraftment, it could be because of nocardiasis, gram-negative bacteria, and Legionella as well. And this is air crescent sign, which occurs later on. And then, how about this one? On the right, what do you guys see where the arrow is? Shout out. It's a nodule with halo sign. And how about on the left? It's kind of the opposite, right? It's like reverse halo sign where you have increased consolidation around and cavitation, or it starts thinning out in the middle. So this is a reverse halo sign. What do you guys think might be the etiology of this? Right. So could possibly be organizing pneumonia. Very good. In terms of infectious causes, mucor, yeah, very good. Mucormycosis usually more than aspergillosis, and like you mentioned, mimics of infection can be cryptogenic organizing pneumonia. And then the issue with these is that because they're angioevasive, these patients can develop hemoptysis and have massive hemorrhage pretty quickly. So if you see this and the patient's on the borderline of whether they need to be in the ICU or not, there's probably some of these patients that should be monitored in the unit. They'll have other factors that will make them really ill as well. So these are patients that can decompensate very quickly. And other patterns, on the left, you see PCV pneumonia. Usually in HIV, you'll see cysts as well. And then on the right, we see ground glass opacities with miliary and like central lobular nodules, and this can be CMV pneumonitis. Okay. Next case, we have an acute myeloid leukemia patient, status post match unrelated donor hematopoietic stem cell transplant, day 3. He's febrile, has neutropenia, and we see this. Could be bacteria, yeah. Fungal, yeah. Day 3, yeah, absolutely, bacterial fungal. What do you guys think these nodules are? Yeah, very tiny nodules. If you get more imaging, you see them in the liver and the spleen as well. TV. So this is disseminated candidiasis. So if you see small randomly distributed nodules, hepatosplenic microabscesses, usually cultures will be positive for Candida as well. But that's another one they're prone to, and we prophylax for Candida as well. Okay. We talked about CMV pneumonitis a little bit earlier. This is usually in the timing from engraftment on to up to day 100. Usually at that point, patients will have T cell deficiency. And the highest probability of this occurring is in patients who are recipient positive and donor negative. So it's the opposite of solid organ transplants. Sometimes diagnosis is somewhat difficult because they'll be PCR positive, but they won't have infiltrates. So infection does not equal to disease. So especially when it comes to pulmonary infections, if they have opacities and they're PCR positive, that would indicate that they have CMV pneumonitis. PCR in itself is somewhat difficult to tell if they actually have CMV pneumonia. And they can continue to shed even once these opacities resolve. Unfortunately, we don't have treatment for this. We can prophylax these patients with letermovir, as we talked about before, especially in patients who are donor negative and recipient positive. Okay. Moving on to if there are no pulmonary opacities, what do we do? And patients are otherwise stable, but they have respiratory illnesses. In these patients, in the outpatient setting, we'd want to get PFTs. It's very hard to get PFTs or spirometry inpatient, but PFTs themselves can help us determine if there's non-infectious etiology of lung disease in these patients. And we'll distinguish between if there's a restrictive pattern or if there's an obstructive pattern. Obstructive pattern with air trapping or hyperinflation, we'll think of pulmonary graft versus host disease as a manifestation of bronchiolitis obliterans. And if there's a restrictive pattern, that can be because of organizing pneumonia or because of new onset interstitial lung disease in these patients. And occasionally they can have a mixed picture as well. So moving on to non-infectious causes, the most common non-infectious pulmonary infiltrate that we'll see in stem cell transplant patients is pulmonary edema, which carries a good prognosis. If you diurese them and they don't have infectious etiology, they do really well. Idiopathic pneumonia syndrome here in the middle, DAH and peri-engraftment respiratory distress syndrome are subsets of IPS. Peri-engraftment respiratory distress syndrome usually carries a much better prognosis than DAH. DAH, unfortunately, carries a much higher mortality. And idiopathic pneumonia syndrome outside of DAH usually looks like ARDS, and that carries very high mortality as well. And we'll go over each individual case. So looking at the patterns of idiopathic pneumonia syndrome, they can present like DAH, acute interstitial pneumonitis, and then organizing pneumonia as well. And then if we look at risk factors for this is allogenic transplants, myeloablative a lot more than non-myeloablative, and if there's prior lung dysfunction. And the thought is initially chemotherapy and radiation will initiate the process of capillary and epithelial inflammation. This is propagated by the donor T cells, so mostly in allogenic transplants. And this in turn leads to epithelial injury and endothelial injury, and that'll in turn lead to diffuse alveolar disease, and that can manifest either as diffuse alveolar hemorrhage or as ARDS. So usually this will occur somewhere between 15 to 30 days. We'll treat usually with steroids. In some institutions, they use etanercept, and there's some controversy about that. There hasn't been any proven mortality benefit in it, and these patients usually carry a high mortality at 1 year. About 50 to 70% of these patients will end up dying. Diagnostic criteria for this has to be established. Patients usually look like they have pneumonia. They have widespread alveolar injury, but they'll usually not have anything growing on their BAL or tissue cultures. You have to rule out cardiac and renal causes of volume overload or edema in these patients. You can have pulmonary edema, but it cannot be the sole reason why they're having pulmonary infiltrates. So they can coexist, but they can't be the sole explanation of why you have an abnormal chest CT. Okay, so we'll take a look at this one first. This is a 30-year-old man 9 days after autologous stem cell transplant, and this is his CT. Okay. All right. PCV possible, probably more ground glass. I'll play it one more time. Could be atypical infections, yeah. Right, so septal thickening, we can see the lobules, which, yeah, like you mentioned, atypical bacteria. But if this is non-infectious and it's an autologous patient, about 9 days. IPS, yeah, 1 under IPS, what do we think? So either it's, yeah, pulmonary engraftment respiratory distress syndrome, and these patients respond pretty well to steroids. So usually what you'll think of at this time is that they'll have a diffuse rash, fever, and non-cardiogenic edema, and you got to rule out acute graft versus host disease, which will usually manifest with GI symptoms as well as a rash. Pulmonary manifestations are not usually typical of acute graft versus host disease. They can progress with to pulmonary infiltrates, but not usually at the beginning. Steroid doses, they respond pretty well. The earlier you start steroids, the better these patients do. So it's something that we should keep on our differential in addition to infectious causes. At the time of engraftment, if we've ruled out infectious causes and they have the septal thickening along with a rash and fever, think about peri-engraftment syndrome, because if we're started on steroids, they do really well. And this can occur in autologous patients as well as allogeneic. How about this patient? So day 17 after myeloablative allogenic stem cell transplant, shortness of breath, dry cough, got antibiotics, started treated with diuretics, and it's getting worse in terms of hypoxia, and now intubated. And this is the CT. Could be CMV. DH, okay. And you do a bronch, and this is what you get. So progressively more bloody aliquots on bronch. In the past, this was about 10% of all allogenic patients. More data now has shown that this is less and less common. It's about 4% now. Moderate dose of steroids works and reasonably well in these patients, about 1 to 2 milligrams per kilogram for 7 days, and then you taper it. higher doses than that have shown to have worse outcome. The other issue is that not only do they have some of these patients lag behind in terms of engraftment of their platelets. So studies have shown if their platelet count is less than 80, they have a higher rate of bleeding. And a lot of these patients are transfused with platelets. The problem is that there haven't been any studies that have shown that if you transfuse to keep the platelet count greater than 80, that these patients will do better. So unfortunately, this carries a very high mortality rate. So moving on to non-infectious pulmonary cause in the late stage, so beyond day 100 in these patients. So chronic graft versus host disease is the most relevant and common complication. And they're usually exclusively in allogenic stem cell transplant patients. Occasionally, you can get GI involvement in autologous patients. This is usually from the donor T lymphocytes attacking the host tissues. And the clinical features are usually diarrhea, rash, GI symptoms, and then they can commonly have lung involvement as well, up to about 50%. Okay. So we have a 30-year-old man, had a history of severe aplastic anemia, shortness of breath for 3 months. What do you guys think of the chest CT? Okay. Air trapping, very good. Yeah, so air trapping, increased attenuation followed by decreased attenuation. What about the PFTs? There's obstruction, yeah. And then decreased DLCO, and then the residual volume's elevated as well, right? So what do you guys think this patient has? BOS, yeah. So BOS is a manifestation of pulmonary graft versus host disease. Can occur in about 5% of allogenic survivors, and usually they'll have indolent symptoms. They can be seen in the outpatient setting where they have a dry cough, decreased exercise tolerance. We'll usually get PFTs and imaging that'll help with this. Ideally, we'd want a tissue biopsy for confirmation, but not every patient can tolerate this. They'll usually be on steroids and immunosuppression otherwise for chronic graft versus host disease, or this may be the first manifestation. So they'll be started on immunosuppression for that, but that can be tapered down. And the backbone of the therapy is something called FAM therapy, which is fluticasone inhaler, azithromycin, and montelukast. And then we'll get regular PFTs to monitor how they do. So establishing the diagnosis of bronchiolitis obliterans, we want PFTs and expiratory films to show air trapping. And this is a little different than the pulmonary transplant patients, which follow the ISHLT guidelines, which came out in 2019. This is from 2014, which is the Modified National Institutes of Health. So you have to show pulmonary function tests that show obstruction and air trapping. And in addition, you'd want either tissue biopsy or CT findings that confirm air trapping. And you got to rule out infection in these patients. So what you see on the pathology slides is lymphocytic infiltrates that are constricting the bronchioles and shortening the diameter of the airways. Okay. So which of the following PFTs is not usually seen in BOS? Any takers? Shout out. Decreased CO, so that's correct, right? So restriction on PFT is not usually a recognized feature of bronchiolitis obliterans. So risk factors for developing BOS, which of the following wouldn't be? I know there's a lot on there. So any one that's not? Okay, that's one thought. Okay, that's one thought. Okay, it's anyone else? It's actually cord blood transplantation. Yeah, actually, Hafsa brings up a good point. Viral respiratory tract infection actually within 100 days, if it's a respiratory syncytial virus or metapneumovirus or any viral illness, they actually have a higher chance of developing bronchiolitis obliterans. They'll have the infection, recover, and then start having shortness of breath again. And that's when you'll see changes in their PFTs. So, and I think that occurs in lung transplant patients as well. yeah, the rest of the other ones are risk factors. So we looked at this slide before. It's get PFT, see if there's obstruction or restriction, and then match it with the CT findings to look for air trapping and mosaicism. And if that's the case, look for bronchial blight, be it BOS, or if there's a restriction, think of ILD. So as we talked about, this usually occurs after 100 days for the first 2 years. It's about 12 to 18 months after a stem cell transplant. Some patients will have a rapid decline, and other patients are slowly progressive and fare a lot better. So the question is, in patients who are followed in the pulmonary clinic, when would you get PFTs? So you'll do screening at 100 days and then at a year after transplant. And if they get diagnosed with chronic GVHD, you'll screen them then. If they're doing okay, do PFTs every 3 months, at least up to 2 years to see that they're stable. So treatment for this, we talked a little bit about FAM therapy. So it's inhaled fluticasone, azithromycin, and montelukast. The inhaled corticosteroids is fungible, so they could use Symbicort as well. There's some data that show that that has modest effect. There's some controversy surrounding azithromycin. In France, there was a study that looked at starting azithromycin at the time of conditioning, so at the time of transplant, and those patients actually did far worse. So there was a black box warning of not starting monotherapy with azithromycin at the time of transplant. In institutions around here, they usually will not start azithromycin at the time of transplant, but usually at the time of diagnosis of BOS, and patients usually do okay. And if they continue to worse despite FAM therapy, we could try extracorporeal photopheresis, which we can do here as well. Okay. And ultimately, patients can be evaluated for a lung transplant. There are 2 patients the transplant team follows that got transplant for BOS after stem cell therapy. And there's a few ongoing trials as well. Okay. All right, we'll try to finish quick. Allogenic stem cell transplant patient starts having fatigue, dyspnea, but no fever. Did a BAL, didn't show any neutrophils or lymphocytosis, is being empirically treated with antibiotics for pneumonia, is not getting better. This is his chest X-ray and CT. What do you guys think? And then those are his PFTs. So what do you think of the pattern? Yeah, on the CT scan. If it's non-infectious? Yeah, yeah. So it's likely cryptogenic organizing pneumonia. Yeah. Yeah. And this is what they saw on biopsy. You see these fibrinolytic granulation tissue that's in the alveoli. So non-specific respiratory symptoms usually present with COP. They'll show passage consolidation. You get peribronchovascular infiltrates with rounded irregular borders. You see restriction on PFTs with low DLCO. And this can occur in both autologous and allogenic. The one distinction is that chronic graft versus host disease is associated with COP, but COP in itself is not diagnostic of chronic graft versus host disease. Okay. And these are other various forms of COP that you could see. You could see migrating infiltrates. And this is how you kind of get the reverse halo sign. They'll start up here on the top left with nodule or consolidation, sorry. And then I'll start cavitating around a little bit. And then you'll get this reverse halo sign, and this is at 12 weeks. And this is what you'll typically see, the atoll sign or the reverse halo sign. You could also get this. Any takers on what this is? Or what sign is this? Not exactly, because you don't see a whole lot of ground glass. This is, I only saw this in one textbook here, but it's called perilobular sign. So it's up until now, it's based on this author, it's the only pattern that's associated with organizing pneumonia. Yeah. So this is organizing pneumonia, which is very responsive to steroids. So these three are the progression that you see once you start the patient on steroids. How does the pathology relate to the radiology? So granulation tissue in alveolar spaces will lead to consolidation. That's a typical manifestation, but in stem cell transplant patients, oftentimes you'll see ground glass opacity. So the typical organizing pneumonia pattern won't necessarily be seen in stem cell transplant patients. So always rule out infection first because this can mimic infection. On BAL, you'll see lymphocytosis and a decreased ratio of CD4 to CD8 count. Unfortunately, I think our lab does not do that on BALs here. So, but that might change. And when possible, try to get a tissue biopsy. Steroids work really well for organizing pneumonia. You'll usually start them on 0.75 to 2 milligrams and then do that for 4 weeks and taper. Unfortunately, relapses are pretty common in these patients. So difference between BOS and organizing pneumonia, PFT patterns will be different, and then their CT patterns will be different as well. Okay, very quickly. Male with allogeneic transplant presents 10 years after transplant with shortness of breath. What do you guys think? He has a pneumothorax. And then it gets better, but then he still has this on there. What do you think were the arrows pointing? Pleural thickening, yeah. And then some interstitial changes more on the apices than at the bottom. So this is pleural parenchymal fibroelastosis. It's a very rare disorder, usually occurs late in stem cell transplant patients and lung transplant patients, and it's characterized by upper lobe findings, apical caps, pleural and subpleural thickening with volume reduction and traction bronchiectasis, usually in the predominant upper lobes. And it can be associated with pneumomediastinum and pneumothorax. These patients, early evaluation for lung transplant is really the only treatment. On biopsy, the gray part is the elastic tissue, and then the pink part is the fibrosis. Okay. Other things that we want to talk about is PVOD, PTLD, air leak syndrome. PVOD, PTLD, PTLD a little bit more common, PVOD mostly in pediatric patients, and then delayed pulmonary toxicity syndrome. Pulmonary cytolytic thrombi also in pediatric patients. This is like last slide of patterns. What do you guys think on the left? This is drug-induced pneumonitis. What about the next one over? Ground glass opacities. It's bleomycin-induced pneumonitis. What about this one? The one on the far right corner. That's not bleomycin. No. That's actually reoccurrence. How about the one on the bottom left? Possibly, could be. That is organizing pneumonia. How about the one in the middle? That's typical DH, yeah. And DH, you'll have like subpleural sparing because of the lymphatics. The pleural lymphatics will absorb some of the hemorrhage. So how about the one after that? Yeah, that's what I was saying. It's actually mucor, but yeah, close enough. And the last one? What about the last one? That's just COVID. Could happen in stem cell transplant patients. So I'll finish up. Remember, always with the pulmonary complication in stem cell transplants, know the timing of transplant, type of transplant, degree of immunosuppression. If they have chronic graft versus host disease, they get pulmonary manifestations of that. Look for infectious versus non-infectious in your differential. And then look at the pattern of the CT. Try to get bronchoscopy with BAL done early. and in the combine that with your pulmonary function test to see if it's BOS versus organizing pneumonia or new onset interstitial lung disease. And this is the website if anyone wants to be a donor. They'll do it online and they'll send you the kit. Any questions? Yeah.
One question and a comment. Question-wise, in your review, did you ever see any evidence of using TNF-alpha inhibitors in BOS? Not just in the AIP, but like the acute pneumonitis phase. I know there is some evidence, but how about in BOS? I know that there are some centers that do use TNF-alpha inhibitors.
In BOS, no. The lecture that I looked at, there's actually a lecture by a pulmonologist from MD Anderson at CHEST 2020. So they looked at after FAM, they do photoelectrophoresis, and other trials that they were looking at is ruxolitinib, a monoclonal antibody. That's still the trials underway, and there's some promise with that. But the data for TNF-alpha inhibitors was that there hasn't been any proven mortality benefit. But ruxolitinib, that's the one that's still in process. And then there's other ones for BOS that are still coming out. Go back here. Let me see here. There is trials for inhaled cyclosporin and oral neutrophil elastase inhibitors that are ongoing. So, but not that I was aware for TNF-alpha inhibitors.
You mentioned that higher dose of steroids have poor outcomes with DAH.
Mhm.
Why that is?
I don't know why. More than 2 milligrams per kilogram usually they have.
Oh, sorry, my fault.
Yeah, or prednisone equivalent. Yeah.
Oh, per
Yeah,
day. Per day
It has worse. Yeah.
The other thing I just wanted to make just a quick comment was when you mentioned cough,
Mhm.
Organizing pneumonia itself by definition is a clinical, pathological, radiological diagnosis.
Mhm.
When we use the word cryptogenic, what we mean to say is that there's no etiology that's been identified.
Mhm.
If organizing pneumonia has been identified in the setting of chronic graft versus host disease, it no longer is cough.
Oh, I guess
It's
organized
organizing
pneumonia.
secondary to a cause.
Fair enough.
So
Okay.
using the word cryptogenic means that you have ruled out as a pneumonia.
So that's a valid point. The only thing that they're emphasizing that organizing pneumonia in itself is not pathognomonic of graft versus host disease. So if you have organizing pneumonia, it doesn't imply that you have chronic graft versus host disease. It's associated with it, but it's not pathognomonic for it.
Yeah, I agree with that. So say someone has allogeneic stem cell transplant, but they develop a viral infection,
Mhm.
and they can develop an organizing pneumonia secondary to viral infection,
Fair enough. Okay.
which may not be a manifestation of graft versus host disease,
Mhm.
but that would still be op secondary to viral infection.
I see. Okay.
Or in the setting of op or secondary to graft versus host disease, there is a distinction. But when we use the word cryptogenic, it's just semantics.
Oh,
but
okay.
when we use the word cryptogenic, it means that no cause has been identified.
I see. Okay.
And in the setting of having a graft versus host disease, I don't think you can use that.
Mhm. Oh, I see. Okay.
That's
Okay.
part of the-
Okay.
Thank you.
Thanks. Anyone in the chat? Yeah, of course. Yeah. Yeah. They're only in Keynote though. That's so you can open it on your phone. Yeah, let's go. Yeah, let's go. Thanks, sir. Thanks. How do I?
Weird. I don't know why it's not letting you show the cursor. Oh, nice. Yeah, you can do it from there.
Yeah, there we go.
Oh, sweet. That was so good, man.
Oh, thanks. Thanks.
Probably like the first time people have paid attention until the end of a pulmonary. That's
I'm gonna pull this
awesome.
better.
Yeah, yeah, go ahead.
There we go.
Yeah, you sure you signed out from?
Oh yeah.
the
I'm sorry, I'm
Zoom?
not signed up for Zoom.
Just say sign end.
Oh, there are no chats, right? No, no chat.
Oh, yeah, that's a good point. There's no question. Okay. And